I'm Dr. Ahmed Lotfi. I'm a consultant obstetrician and gynecologist. I have been practicing in UK, New Zealand, and in the Middle East. This is a case presentation about eclampsia in pregnancy. Case summary: a pregnant woman presented with generalized tonic and clonic seizures. She has a history of preeclampsia, hypertension, proteinuria, headache, and visual disturbances. This syndrome, preeclampsia, eclampsia, can happen antenatally, intrapartum, or postpartum up to 4 weeks. The diagnosis: eclampsia means seizures in women with preeclampsia. Defined by hypertension, proteinuria. Sometimes there will be an organ dysfunctions, liver, kidneys, heart, and coagulation dysfunction. This syndrome is life-threatening obstetric emergency. Maternal complications: all complications are life-threatening and they can lead to maternal death. Aspiration pneumonia, so the patient has to be in the left lateral position with hyperflexion of the hyperextension of the head and airway insertion, aspiration of the mucus. Cerebral hemorrhage and stroke can be prevented by antihypertensive and anti-seizures management. Disseminated intravascular coagulation should be expected, and it is life-threatening unless it is treated with fresh blood transfusion, cryoprecipitate transfusion, fresh frozen plasma, platelets, fibrinogen, and if these clotting factors are not available to be transfused, then fresh blood transfusion may treat the syndrome. Renal failure with pulmonary edema, it needs a furosemide and restricted fluid, and definite treatment will be renal dialysis. Hepatic failure just needs IV support, and all these complications may lead to maternal death. Fetal complications are fetal hypoxia during seizures and intrauterine growth retardation, premature birth, and stillbirth. Management: first, call for help from senior obstetricians, anesthetists, and hematologists, and laboratory and theater staff. We used to have eclampsia staff ready on call. ABC approach: airway, breathing, and circulatory support in a left lateral position. High flow oxygen, IV access, and monitor blood pressure, pulse, and respiratory rate. Insert catheter and monitor the urine output. Airway should be always maintained open with airway and aspiration of any mucus. Medical management: control of seizures with IV magnesium sulfate, loading and maintenance. Loading is 4 grams within 15 minutes intravenous, and after that 1 gram intravenous per hour with an IV syringe pump. If the syringe pump is not available, then maintenance can be 5 grams intramuscular every 5 hours. We should consider additional bolus of magnesium sulfate 2 to 4 grams if seizures recur. Magnesium therapy needs strict patient monitoring and observation. The pulse, the respiratory rate, the urine output, and the patellar reflex and all reflexes. We should monitor all of this. If the respiratory rate becomes less than 16 per minute. We need to stop the magnesium sulfate. If the urine output becomes less than 25 ml per hour, we need to stop the magnesium sulfate, or with the disappearance of the reflexes, especially the patellar reflex, we need to stop the magnesium sulfate. In cases of respiratory arrest, we need to give calcium gluconate IV as an antidote to magnesium sulfate. Blood pressure should be controlled with labetalol, hydralazine, or nifedipine by boluses and maintenance according to the protocol. Definitive management. The definitive treatment of preeclampsia syndrome is delivery of the baby. First, the patient should be stabilized. This means that we control the seizure and the hypertension and deliver the patient. Multidisciplinary team should be involved with obstetric, anesthetic, ICU, laboratory and hematology, and theater staff. Key points: eclampsia is a life-threatening obstetric emergency. Magnesium sulfate is the treatment of a choice for seizures, and delivery is definitive management, but only after maternal and control of seizure and blood pressure. It requires rapid, coordinated, and multidisciplinary care. This is the end of this presentation. Thank you.